I'm Alan Potash, CEO for the Jewish Federation of Omaha. Tonight's forum is COVID-19, Perspectives, Experiences, and Lessons, featuring a panel of experts. We are certainly fortunate as a community to have access to healthcare professionals who are viewed as global thought leaders, and I am grateful for their participation. Thank you for being available tonight. We have over 200 people joining us on this webinar. Before I turn things over to our moderator, Dr. Frankel, I want to provide an overview of how we have addressed the impact the virus has had at the Jewish Federation of Omaha. If you aren't familiar with our campus and agencies, pre-COVID, we averaged over 1,500 people coming to one of our 8 agencies every day. Whether it was to our fitness center or preschool program at the JCC, or visiting family at our nursing home. It is important to point out that during COVID, we made difficult decisions to continue operations to the best of our ability, while following the recommendations of local, state, and national agencies. Oftentimes, we were out in front of the recommendations. For example, the Rose Blumpkin Jewish Home early on closed the doors to visitors and started taking temperatures of staff while checking for symptoms. The question of testing staff and residents has been an ongoing concern, and the protocols the home has used and continues to use are guided by local experts. The procedures implemented for screening and early detection have been instrumental in keeping the virus away from residents as well as staff. In addition, our Steinberg JCC followed the guidelines from the city and state to open our fitness center, pools, and summer camps. Throughout the pandemic, if someone had had symptoms or was exposed to someone with COVID-19, they were tested. Out of our 450 employees to date, only 19 have tested positive, 2 at the JCC and 17 at the Rose Blumpkin Jewish Home, and 1 resident who had recently been discharged from the hospital. With all these cases, we responded quickly and properly to stop any potential spread. From the beginning, we have been nimble and disciplined in our approach. I know the issue of testing will be one of the topics addressed tonight. Now, I would like to turn it over to Dr. Frankel, who will lead this evening's conversation. To save time, all of the bios of the presenters are on the website. In addition to any questions you have already submitted, if time permits, the panelists will also field questions you pose via the chat feature. A quick thank you to Steve Levenger and Michelle Johnson for putting this event together. Thank you again, and once again, thank you to our panelists and for all of you joining us tonight. Harris, take it away.
Alan, thank you very much. Good evening, everybody. And I'd like to first thank the JFO for sponsoring tonight's event and commend all of you for the hard work that you've done for the community and the overall success that you've had in dealing with this pandemic. I'd also like to especially thank Alan and Steve for inviting myself and my esteemed colleagues to be your panelists tonight. Our goal is to answer frequently asked questions and, most importantly, provide you with good information. Before I introduce our panelists, and I'll ask them just to very briefly acknowledge their roles, I think it's fair to say that all of us have been deeply affected by this pandemic. The various consequences resulting from the pandemic, whether medical, emotional, social, and or financial, have reached deep into the fabric of our communities. I think it's also fair to say that this virus is agnostic to its host. And there's no doubt that some communities or groups have been affected disproportionately versus others. And we can't ignore that. So what I'd like to do is, before we get started with the questions, is I'd like to go around the panelists as I see them on my screen and just briefly tell everybody who you are and what your role is. I guess I didn't do that myself. I think I probably know many of you who are in the audience. I'm Frankel. I'm a neurologist by training and practice. I'm Chief Medical Officer and Chief Compliance Officer for Nebraska Medicine. And again, it's a pleasure to be here. Dr. Bittner.
My name is Marvin Bittner. I'm professor of medicine at Creighton University. I'm a medical doctor with a subspecialty in infectious diseases. And 22 years after I graduated from Harvard Medical School, I moved back in my old dorm for a couple summers to do the coursework for a master's degree. And epidemiology from the School of Public Health. Most of my time is at the VA Medical Center, where I'm Deputy Chief of Staff and have been very involved with our response to COVID-19 in my role as hospital epidemiologist and Chief of Infectious Diseases.
Thank you. Dr. Rupp.
Yes, good evening. Thank you, Dr. Frankel. I'll just start off by saying I'm delighted to join the panel and quite privileged to have such an esteemed group of folks share the virtual podium with me. I'm a professor in chief of the Division of Infectious Diseases at the Nebraska Medical Center, where I also am the medical director of our infection control department and have been involved really since day one with how the medical center has been dealing with the influx of COVID-19 patients. Thank you. I look forward to the rest of the conversation.
Thanks, Mark. Dr. Freifeld.
I'm Allison Freifeld, also a professor of infectious diseases at the University of Nebraska Medical Center, founding and now just recently former director of the Oncology Infectious Diseases Program at UNMC. And I'm honored to share the screen, as is Dr. Rupp, with such an illustrious group of experts. Thanks to Steve Levinger and to Harris for organizing this.
Thanks, Allison. Dr. Johnson.
Hi, my name is Dr. Dan Johnson. I'm an associate professor of anesthesiology at UNMC. I'm the division chief of critical care in our department, and I'm the associate medical director of the Nebraska Biocontainment Unit. And I have been co-directing the critical care response to COVID-19 with my friend and colleague, Dr. Brian Bohr from the Department of Medicine. And I too am delighted to be here tonight.
Dr. Alipour.
Good evening, everyone. Alipour, I'm the director of the Douglas County Health Department. I have been in that role for about 18 years. And as you can imagine, in a pandemic, local public health really plays a major role. I'm really delighted to be here with all the experts of you on this panel, and thank you for inviting me.
And last but certainly not least, Dr. Khan.
Very kind of you, Frankel. Ali Khan, College of Public Health. I also want to thank Steve and Harris and Ellen for the opportunity to join you today. I will tell you I'm joining you from the Tri-Faith building, which just opened today here on the Commons.
Great.
Dr. Frankel, I also would like to make sure that we don't miss Dr. Fay, really important in the laboratory.
Oh, you know what? I'm sorry about that, Paul. I missed you.
Okay.
My bad.
Okay. Good evening, everybody. My name is Paul Fay. I'm a professor and vice chair, Department of Pathology and Microbiology, and also the director of the microbiology laboratory at Nebraska Medicine. And so my role has been to direct all of the testing activities during this pandemic.
Thanks, Paul. And Paul is a superhero, and given all he has to deal with relative to testing. Well, let's go ahead and get started. And let's just start from ground zero. So I want to ask Dr. Bittner, talk to us about the coronavirus. We know that there are multiple different coronaviruses, notwithstanding the one that causes COVID-19, but could you talk to us about, just in general, the different coronaviruses we've experienced, the diseases they may have caused, and then a little bit more specifically about the novel coronavirus that has resulted in the COVID-19 pandemic?
Yes, there are 6 other coronaviruses that affect humans. 4 of them cause the common cold, so most likely a lot of us have got some experience with them. There are 2 that have come to the attention of the world community in the past 20 years or so. There was the SARS virus, recognized in an outbreak that started in China in 2002 and continued until 2003. And more recently, a Middle East respiratory syndrome, MERS virus. And interestingly, some of the countries that have been hit the hardest by these other respiratory coronaviruses, SARS and MERS, places like Hong Kong, Singapore, Vietnam, South Korea, are some of the places that have mounted some of the most effective responses to our current coronavirus, SARS-CoV-2, which is the virus that causes COVID-19. And I've read some interesting tweets from Dr. Khan about approaches that we might be able to take here in the US that in many cases reflect what they've done very effectively without having to go through some of the disruption of a complete lockdown. So there is definitely something to learn from the experience, but each virus is a little bit different. COVID-19 is not quite as deadly as MERS, but it has some important characteristics that the interval from when you acquire it, when you pick it up, to when you start to be contagious is 4 days or so. So what that means is there's an opportunity if we identify people right away, test, trace, isolate, we have a terrific opportunity to really slow the spread. And Dr. Khan may have a little bit more to say about this.
Let me pose Dr. Rupp a question. Mark, could you talk to us about how the virus spreads and at what point does a person become infectious?
Yeah, so the virus does have a lot of similarities to influenza and other respiratory viruses with regard to the mechanism by which it spreads. We're still learning about this, but we think that it spreads a lot like influenza. So droplets spread from people who are coughing and sneezing. And then there is increasing data that as we just breathe and talk and cough and sneeze, we also make smaller droplets that may say suspended in the air for a little bit longer period. And there's probably some degree of transmission of COVID-19 that's due to the small droplet aerosols. This is particularly important in our hospital situations where we have what we call aerosol generating procedures. And we're very careful around those to make sure that we're taking all necessary precautions to prevent the spread. As Dr. Bittner said, you get inoculated with the virus either through breathing in the droplet or touching your eyes, nose, or mouth, and the virus gains access to your mucous membranes in that route. And then somewhere between 2 and 14 days, if you're going to develop symptoms, that's the known incubation period. Typically, it averages somewhere in the neighborhood of, as Marv said, 4, 5, 6 days. The symptoms are pretty well characterized. It initially starts off as an upper respiratory tract disease with fevers, cough, shortness of breath, and then unfortunately can migrate down to the lower airways and cause a very serious pneumonia. And as we've gained experience with it, we recognize that this is really much more of a multi-system disorder, and really any organ system can be involved with the virus.
So thanks. I'd like to direct the next question to Dr. Freifeld. Allison, we heard from Dr. Rupp that there's a spectrum of symptoms in those who become infected. And we know that that may range from being completely asymptomatic to people with really severe complex problems related to their infection. So could you talk about the risk profile of those who are at risk for severe infections in general, and those individuals who may be immunocompromised and what their risk profile looks like?
Sure. So as Mark mentioned, this disease has an extraordinarily wide spectrum, and as you've mentioned as well, a lot of manifestations ranging from asymptomatic, mild or moderate disease in about 80%, but severe requiring hospitalization in about 15%, and intensive care in about 5%. So although as many as 40% are asymptomatic, that shouldn't fool anybody. The truth is COVID-19 can be extremely dangerous, especially in patients with immunocompromise. So that would include patients with cancer, those who've had a stem cell or organ transplant, and also includes people who are obese with a body mass index of 30 or greater, chronic kidney disease, chronic lung diseases like asthma or COPD, diabetes, both types 1 and 2, serious heart conditions like heart failure, coronary artery disease. So probably the most overriding comorbid condition, let's say, or a problem that leads to extreme illness is age. And so I think it's important to recognize that people who are older are going to be the ones who have the most problems in terms of severity of disease, hospitalization, and mortality. But in terms of cancer, I want to mention just specifically, it appears that not all cancer, of course, is the same. There's a lot of variability in terms of types of cancer, types of treatment. But from emerging literature, it looks like people who've had chemotherapy within the last 3 months are at higher risk. Those with lung cancer specifically, as opposed to breast or colon or another solid tumor, are at greatest risk. And those with hematologic malignancies, that is leukemia, lymphoma, or multiple myeloma, are likely to have unfavorable outcomes.
Great, thanks. So, Dr. Johnson, we've heard reference to severe illness, and oftentimes we hear about critical care illness. Can you talk about in general what it means to be critically ill, and more specifically what you've personally seen and dealt with in your role as a critical care physician related to persons with COVID-19?
Sure. Being critically ill means that you are at risk for dying, or you are at risk for losing organ function. So perhaps you're going to lose your lung function or your heart function, kidney function, liver function, any major organ system. If you've lost that, you are critically ill. If you are at serious risk of losing that, you're considered critically ill, and we put you into the intensive care unit. With regard to COVID-19, by far the biggest problem that we've seen is what's called respiratory failure. So that's the inability to get adequate oxygen into your body, or the inability to get carbon dioxide out of your body. And frequently those two things go hand in hand. And with COVID-19, that's been no exception. We've seen this with influenza in the past, but we haven't seen it in the numbers that we see with COVID-19. And we certainly have never seen a viral respiratory illness that causes people to require ventilator support as long as we do with COVID-19. Some patients with respiratory failure end up needing a breathing tube, needing to go on a mechanical ventilator. And then some of them have what's called ARDS, or acute respiratory distress syndrome. The short explanation for that is just that your body is needing very, very high concentrations of oxygen from the ventilator, very aggressive, potentially damaging pressures from the ventilator in order to get oxygen in and carbon dioxide out.
Great, thanks. I want to shift gears for just a minute, and I want to address the concept of public health. And so, Ali, could you talk to us about what is public health, and what is it? What is the role of public health experts in a pandemic?
Oh, thank you very much. Glad to talk about public health. So public health is what we do as a community to make sure all of us can live healthy, productive lives. And so this is gets to, in this specific pandemic where we're trying to decrease community transmission, it's all the activities we're doing to identify who's sick in the community. And as Dr. Bittner said, how do we test, trace, and isolate them? How do we keep sick individuals from infecting others? And then what are we doing as individuals in the society to make sure we're wearing masks, we're washing our hands, and we're socially distancing? So those are some of the public health measures we take collectively and individually to protect the health of everybody within our community.
Great. I want to ask you a follow-up question. So what lessons learned from the Spanish flu epidemic of 1918 have we applied to the current COVID-19 pandemic?
So surprisingly, a whole lot of them. So let's start.
Whoops. Ali, you froze. So we'll digress for a minute, and I'll shift my attention to Dr. Poor. Adi, thanks again for joining us. Talk to us about the role of our county health departments in general and the work specifically done by you and the Douglas County Health Department relative to the COVID pandemic.
Sure, I'm glad to share that with you. So, you know, all the testing that we are talking about, and Paul Fay can talk about that a little bit more, but the laboratory need to report to the state by state statute. That information then is being shared. If the resident is of our county, will be shared with us. So we are getting, every day, we are getting hundreds, if not thousands of laboratory tests. Once we get those tests, we take the negatives, deduplicate, and do all that work. Those who are positive then are going to be referred to a contact tracer. What that contact tracer is doing, and at this time, we are potentially have around 100 of them. 20 inside the health department. We also have a contract with PRC, which is a local consulting company who does work for us during the year on community health needs assessment. Now they are doing contact tracing. So those contact tracers will follow up with those individuals who are positive, then try to find out some information of them, give them recommendation what they need to do. And if those contact tracers actually find out and say, you know, you are positive, do you need any additional help? If they say, yes, we do, they will be transferred to our navigators. And those navigators actually will try to find out what are the needs. Are they food needs? They cannot stay at home. We need to make sure that they are having food delivered to their house. Is it utility needs? Is it transportation that they need, or so on? So that's a navigator group. So we are really taking care from the beginning of when we get the test results. And of course, we have this overall assessment function of the community. When people want data specific to this community, they come to local health departments, because you all have different data from your health systems, but you don't have it from all of us together. The other thing, the other thing that we are doing, we have vital statistics office. We are the only local health department in Nebraska who has a local vital statistics office. So that's for birth and death records. When the death records come in, they are being looked at to be complete. And from that death records, then we are determining if this is a COVID-related death or not. We may go back to the coroner, get some more information. So that's where we get the information, how many deaths do we have in our community. The other thing, hospitalization, we collect that data that comes in through the Knowledge Center, and we share that. What we do after about somebody is identified as being positive, about 3 weeks later, individuals call them up again and say, have you recovered from your symptoms? Because we want to know how many of our people in the community have recovered. And so everyone gets a phone call back. The other thing that we are doing is we are trying, through the contact tracing, we are trying to identify clusters. And we have a cluster report. We have more than 420 clusters as of today from the beginning of the pandemic. Some of those clusters are small and some of them are big, especially those in the meatpacking plants. Those were huge clusters. The other thing we are doing now where we are really involved is with the schools, with the local schools, to try to help them first to develop kind of some strategies. What are really important points that you need to look for before you open your schools? And now that with the school nurses, try to work with them together and say, if we have a first case in a classroom, the school nurses can do the first round of information, so to say, then share it with our epidemiologists and disease investigators, and we then determine who else needs to be quarantined potentially in that school. The other thing that local health departments have really been involved with is the long-term care facilities. So we have ICAP at the Nebraska Medical Center, which is a fabulous resource to really look at infection control practices in long-term care. But what public health does is actually we identify and measure when these long-term care facilities have outbreaks. We also now have the point person, so to say, for test kits for the long-term care facilities. So we make sure that they have enough test kits to do baseline testing. The other thing that local public health, and that has been a decision a little bit from the governor, we have now become a distribution center. We have distributed more than 3 million pieces of PPE for our healthcare providers in Douglas County. So the actual order goes in electronically now to state government, who then orders the PPE out on the free market because they can get a better price for it. That PPE comes back to local public health and we give it out to our healthcare provider. The other thing that we have done from the beginning is we have learned that from Ebola, that this community really needs an information line. They need to have a hotline where they can call in with questions. So since the beginning of this pandemic, we have had this hotline 7 days a week. We have more than 20,000 calls that we have now received on that hotline. And in the beginning, as you can imagine, they were, well, what is COVID? What are the symptoms? These calls are now getting very intense and can last longer than half hour, where individuals are asking, you know, I have potentially this exposure. What do I need to do? They want test results. Now with the mandates, we try to explain to them what does it mean to have the mask mandate. They are complaining if somebody isn't following the mandate. So that has really become an important point for us. The other thing that we do, we are always a little bit the gap filler in the community. Where is there a specific need? But we have determined pretty quickly in this epidemic, especially in the beginning, that our Hispanic population is disproportionately affected by this virus. So we have tried to make sure from the beginning that there is enough testing, that opportunities for that community. So One World in Charles through the Federally Qualified Health Center, but potentially since the second week of this pandemic, they have had as much testing as possible that they can handle. So we know that they are the trusted resources in the community, and the Hispanic community can go to them. We now had a site up for about 9 weeks with the partnership with Nebraska Medicine on 50th and G, specifically for that community. And that is what is the public health's role, really, to see what do we need to do so that everybody can have the opportunity to get tested and treated in our community. So that's in broad what public health is doing.
Thank you very much. And that's a great segue to begin to address the topic of testing. So Paul, I'm going to turn it over to you and let you tell us about the different types of testing available, whether there's one test that's better than another. I'd like you to also address the issues of supply chain problems that we face relative to testing. And then lastly, if you would address the issue of antibody testing, because that's different than PCR or antigen testing that I know you'll address. So I'll turn it over to you and anxious to listen.
Yeah, thank you. So I think that there's one major way that we perform testing, and it's called PCR testing. And it's a very sensitive assay, and most laboratories that you're going to be sending your samples to, which are going to mostly be nasopharyngeal swabs, are going to be doing PCR testing, and it's a very sensitive test. And we're very proud of the tests that we've developed and the sensitivity associated with those tests. But one of the challenges of the tests is that there's a real supply side issue, supply chain issue. So what that means is that even though we have the capability and the infrastructure to test a lot of different patients, we just don't have enough tests available. In some cases, we don't have enough of the pipette tips or other types of things that go inside of the instruments themselves to actually do that many tests. So we would really like to be able to test a lot more people, but right now, I think that our main testing strategies are to test those people who are ill, those people who are having pre-procedures, a pre-procedural screen, and also to work with Dr. Poor and other public health partners to test populations at risk. And so we really have two main focuses right now with public health as well as symptomatic people with our testing. So again, I think our testing is very sensitive. I think you've probably heard a lot about other types of testing platforms, these rapid tests. Probably heard a little bit about rapid tests for instance, with saliva and other types of specimen sources. And I think that those particular tests that you hear about, these rapid tests, have their place in our testing algorithm. And I think most of that will be in testing for people who are acutely ill or particular populations such as athletic teams, or potentially we could be testing schools or other types of specialized populations that we need to know those particular people who have acute cases of COVID. So I think that we really should start to implement those types of testing strategies within, again, our COVID infrastructure. So the other question was about antibody testing. And so we also have tests to detect antibodies against the virus. And at this particular point, antibody testing, there are some clinical situations where it could be important. For instance, if you think that you may have had COVID, but you tested negative, so your physician may want to get antibodies to see if you've generated antibodies against the virus. But those situations are pretty rare. So at this point, antibody testing is more of an epidemiological tool or a public health tool to see how many people within a population have been exposed. And I think those are really interesting data coming out with antibody testing. But I think it will be very important when we have a vaccine, because we're going to need to have antibody testing available to ensure that people that have had a vaccine have responded to that vaccine. So antibody testing will become very important, I would say, within the next 6 months.
Great, thanks. I'd like to go back to Dr. Rupp and ask Mark, you know, we hear a lot of people ask the question, should I get tested? And I think we have fairly clear-cut criteria as to who should be tested and who doesn't necessarily need to be tested. Could you address that?
Yeah, sure. So I think that, you know, priorities for testing are somewhat driven by the capacity for doing the testing, as Dr. Fay related. You know, clearly we want to make sure that anybody who has any kind of a clinical syndrome that is consistent with COVID has ready access to a test. And so that is, you know, clearly a priority. We want to make sure that anybody who's a healthcare provider that likewise has symptoms gets promptly tested, and first responders and the like. There's certain vulnerable populations that it's shown to be, you know, useful to do broad testing, even if people are asymptomatic. And so in our long-term care facilities, some other, you know, congregate living situations, homeless shelters, those are the places, prisons, where, you know, testing folks who may not be exhibiting symptoms make a lot of sense. You know, if the world was perfect and we had an easy test that we could do rapidly and give people results on the spot, then, you know, we would want to be testing broad swaths of the population. But that situation just doesn't exist right now. So we're having to prioritize testing still to some degree. You know, should you get a test, clearly, you know, again, if you're having any symptoms, that would be important. And then if you've had a really close exposure, so like a family member or somebody else who's clearly been defined and, you know, at some point in the incubation period, if you were tested, that might be useful in certain situations as well.
Thanks. I see Dr. Khan has joined us once again, so I want to give him a chance to finish his response. I think you left us as you were starting to talk about lessons learned from the Spanish flu epidemic of 1918.
Oh, yeah. Thank you and apologies. So there's a lot of things that we did in 1918 that we're currently doing, and it shows you how robust and resilient public health is and how old these tools are. So we were using masks in 1918. We used quarantine in 1918 for soldiers who were coming back from Europe. Social distancing and lockdowns were very quickly recognized that if you keep people far away from each other, you don't join parades, they would do well. But my most interesting one is about open air and adaptive schools. So during that time, New York had this effort to get people out and about, the kids out of schools, and they had like over 100 or 150 open air schools so that they can educate these kids during 1918 with them not getting infected. And the last piece for any of those who've spent any time in New York City is subway tiles, white subway tiles. They come from that era about hygiene and keeping everything nice and clean. And that's where those white subway tiles arise from. So all of those things now have moved forward 100 years to today.
Great, thanks. I'd like to ask Dr. Freifeld to reflect back for a minute on some of the comments she made about those individuals who may be at higher risk for severe disease. And The question I have for you, Allison, is the following. We know that there are many individuals probably on this call and within our community that are immunocompromised for various reasons, but yet have asked the question, can I travel? And can I travel safely? What are your thoughts about that?
You know, I think each individual has to kind of make an assessment of their own health risks and their mode of travel as well. There's a lot of information out there about airplanes, for example. I think there was one study that just came out to assess that and indicate that because airplane air is 99% HEPA filtered and exchanged every 2 or 3 minutes, that it's actually relatively safe as long as you're wearing a mask the whole time. Better if you're seated farther apart from other people. But, you know, people who are in certain risk groups, and I mentioned some of them, but I want to extend that and kind of mention to you that diabetics, for example, have a 2 to 3 times greater likelihood of severe infection or ICU admission and even mortality. On the other hand, patients who are taking biologic agents for rheumatologic diseases haven't been found to necessarily have an increased risk of severe or unfavorable outcomes. So, you know, these are things that you need to sort of personally take stock of and know that also if you're in a certain age group and you also have one of these or more of these associated risks, your possibility of, if you do acquire COVID-19, having a difficult course is going to be somewhat higher. So I think that, again, it's just a matter of thinking about, do you really need that trip, and where you are on the risk scale.
Thank you. Marvin, question for you. So we're approaching the flu season, and the question I have for you is the following. If a person tests positive for another flu virus, does that rule out COVID-19 as being the cause of their illness?
My thought would be no. Several months ago when we started doing testing, we would first test for a panel of different bugs that can affect the lungs. And if we came up with some evidence of infection from some other virus, you know, including influenza, we'd say, haha, that's what's causing the problem. It couldn't possibly be a case of COVID-19. As we got more experience, we found that there were folks who would have positive tests for something else like influenza and also for SARS-CoV-2, the virus that causes COVID-19. So we changed our approach, and we weren't, you know, about to dismiss the possibility of COVID-19 just because we could find evidence of a test with another virus. Now, things have gotten a little bit more complicated as we've learned more. We've had to change our approaches, and there are several wrinkles. One is that we still have the very strong general advice. If you're over 6 months old, you need to get influenza vaccine every year. There are very, very few exceptions. There's even a virus that's made totally without eggs in any way, shape, or form. So if you're worried about egg allergy, that's no longer an excuse. So we have a very strong recommendation. If you're over 6 months of age, there are very, very few people who should not get the influenza vaccine every year. Now, one of the wrinkles is that we can look at what's going on in the southern hemisphere right now, where they've had, as we have, experience of having dealt with COVID for several months. And what's happening there is they're hardly seeing any influenza at all. It's the sort of thing where you might have a large country and maybe count the number of cases that are positive on the fingers of one hand. So it may be that some of what's going on with the precautions that people are taking are cutting down the risk of influenza. We really don't know, and I would still recommend influenza vaccine for everybody over 6 months every year. So I think the short answer is that there's some ambiguity. There's not some clear answers. Traditionally, we say you can only have one viral lung infection at a time. We've definitely come up with people where the tests pick up more than one. There are a number of possible explanations for this, but when you get down to practical advice, everybody over 6 months, with very few exceptions, needs to get influenza vaccine every year.
Great.
I don't know if that answers your question now, Harris.
Absolutely. It was an excellent answer, Marvin. So what I'd like to do just for a minute here is we've got a couple of questions on the chat box. And so I'll just open these to the panel. So the first question is the following. It seems to me that the most important statistic that the media does not share, and I think Nebraska has not tracked, is new COVID-19 hospitalizations each day. Why do we not get this nationally, state, and locally in cities?
We have been tracking that very closely in Douglas County and in the state of Nebraska. I wake up every morning and that is the first thing that I look at, actually, because I need to know how to staff the ICUs at UNMC. So it is available. If you go to the Douglas County Health Department dashboard and the state of Nebraska Department of Health and Human Services dashboard, you can track it each day.
Thanks, Dan. I'll just chime in. I'd be really very complimentary of our public health services, both at the state level and even more particularly at the Douglas County level, for the transparency and the granularity of the data that's reported. Within Douglas County, Dr. Poor has insisted from the very beginning that this data is reported by race, by gender. There's just a wealth of information out there. Folks are working really, really hard to get information into the hands of the public. Unlike any other infectious disease outbreak that we've ever seen in the past, people can really, really know what's going on a day-to-day basis within the country, in the state, worldwide.
Yeah, I'd like to echo Dr. Rupp's comments, and specifically the compliments he's paid to both our state and local health departments. They've really done yeoman's work in this regard, and we're very lucky to have those people working on our behalf. So let's shift a moment to treatments. We've heard a lot in the news about a variety of different treatments, from things tried like hydroxychloroquine to remdesivir to methylprednisolone. So I'll open it up to whoever wants to address that. Those that have had experience, Mark, Dan, take it away.
Well, I'll start and then I'll turn it over to Dr. Johnson, who's really worked very, very closely with some of the critically ill COVID patients. But we've come a long ways in the last several months in knowing how to better treat people with COVID-19, whether that means better supportive treatment with regard to fluids or ventilation schemes or anticoagulation or specific treatments. And so we're very proud of the role that Nebraska Medicine has played with the NIH-sponsored trial. We were actually the first center in the country to enroll a patient into the remdesivir trial. This is, I think, an excellent example of how one can do really cutting-edge research in the midst of an outbreak. And so this was a placebo-controlled, double-blind trial that really did answer the question of whether that drug is useful in the treatment of patients with COVID-19. And unfortunately, what we see with some other modalities of treatment is that people are in such a rush to offer therapy that they don't do it in a way that we ever really figure out if it's useful. And so again, the remdesivir trial is a great example of how we really do know the populations that we can be using that drug and doing it in a way that's helpful to patients. Likewise, there's some similar data with dexamethasone that in certain patients it is proven to be helpful. And there's really just a whole host of other trials that are ongoing with regard to monoclonal antibodies, polyclonal antibodies, immunomodulating agents. So really a lot of information that's coming out. And I'll turn it over to Dan now because again, he's had really some personal, experience with treating these patients in our ICU.
Thanks, Mark. Yes, the two that have been proven so far are remdesivir and dexamethasone. More will come. A couple quick points on that. Number one, I know there's so much out there on social media, and even there's physicians that are on YouTube and social media that are purporting to have the answer to COVID-19, which I hope is true down the road. We have to rely on randomized controlled trials to tell us what works and what doesn't work. Just because patients do well on a drug doesn't mean they do well on that drug because they took the drug. We have to compare them to placebo controls. And that's what was done with remdesivir and to a lesser extent dexamethasone, but it was a large enough trial that we think there's signal there. The really number one thing to do to keep people alive who are critically ill with COVID-19 is provide optimal supportive care. And that depends. So that means being able to give everyone who needs a ventilator, everyone who needs an ICU nurse, a respiratory therapist at the bedside in an appropriate room. And there were parts of the world, particularly Spain, Italy, New York City, where they had so many cases in such a short period of time, they weren't able to provide optimal supportive care, which is every healthcare worker's nightmare. So part of the reason why a lot of us have been out there really trying to help people understand the importance of wearing a mask, using social distancing, doing hand hygiene is because in Nebraska, we've been strained, but we have never been fully overwhelmed. We've got one of the lowest mortality rates in the country with regard to COVID-19. We want to keep it that way, but the only way we can do that is to continue to be able to provide optimal critical care when people are really sick. Because once you've got 5 patients for every ICU nurse, once you've got a hospital that's completely full, once you've got floor nurses trying to do ICU nurse work, that's what was going on in New York, Italy, and Spain. And that's when people really start to die at a much higher rate.
Thank you. Another question from the audience, and I'll direct this to Dr. Poor. Insofar as deaths are tracked, are we counting deaths that are COVID related, or do we only count deaths that actually died as a result of COVID-19?
Great. This is a great question that we get often, and we count both. COVID-19, however, needs to be on the death certificate, so it can be related or due to. The other thing that we only will call a mortality due or related to COVID if that individual actually had a COVID test. So we go back and check the records then and our database to make sure that that individual was a case to it. We want to be very clear with this because this has gotten a lot of criticism. So COVID has to be written on the death certificate by the physician, and the COVID test had to be done.
If I may add, the number of deaths that we're counting in the US are probably 33 to 50% less than the actual number of deaths when you look at excess mortality. So trying to granulate between COVID related or COVID actual doesn't make sense because there's an extra 50% out there that aren't being counted at all. So currently there's probably 210,000 deaths in America, even though we're only reporting 170 by COVID tests.
Thank you. Allison, question for you. And this relates to the comment you made about one of the major risks really being age and the elderly. We know that children can be asymptomatic carriers, and some have suggested they could be, super spreaders. If I'm a grandparent with some chronic disease, what would the advice be to spend time with my grandchildren? Oh, you're on mute.
That's a very difficult question. I'm a grandparent myself, and I know how difficult it is to be asked to not or be kept away from your grandchildren. But I think this is a situation where if you do have one of those risk factors, it's extremely important for you to be careful in terms of how much interaction you have with grandchildren. You're absolutely right. Kids, infants, all the way up to young adults are going to have, as if they are infected with SARS-CoV-2, are going to have as much viral material in their nose and throat as adults, and they can easily transmit that virus. And frequently, for the most part, they're going to be asymptomatic. So, if you do have one or more of those risk factors that I mentioned, if you're over the age of even 60, I would say you need to be extra careful. And that's particularly if you have young children, grandchildren, that is, who are going to daycare or to school. And I think that, opens up that entire problematic scenario that we're dealing with now regarding school. Now that schools, at least some of them, are open in person, the chances are that we're going to see more spread within schools, and that people who are in those high-risk categories are going to have to be even more isolated, I would say. So I think you have to really be careful about interacting with young children and older ones too.
Great, thank you. This is another question from the audience that was submitted. Paul, I'll direct this to you, and I'm just going to paraphrase this. We've now heard about the new saliva test that was developed from Yale and University of Illinois. Is this the answer to solving the Big Ten football season?
Well, so the issue with the nasopharyngeal swab, which is a small swab, and you stick it up to your nose and you capture some cells in the back of your nasal cavity. That is by far the best specimen that we can get for COVID. And so we prefer for all of our tests to use that particular specimen, especially in some of our complicated cases that we have at Nebraska Medicine. However, that being said, I think that one thing we do know is that saliva is a fairly good specimen. I would call it an adequate specimen if you have an acute case of COVID. So if there are tests available that we could use again in certain populations, such as Big Ten football players, to on a daily basis test them, I think that is a really an appropriate use of that testing methodology. And so if we would have saliva, somewhat non-invasive specimen, and test everybody as often as they can, if they could get supplies, then I think that's a really good approach. I really do. Great,
thanks. Marvin, a quick question for you. What's the likelihood that we're going to have an effective vaccine? And what do you think the timeline is before it's available for widespread use?
It does remain an open question. I think the good news is that there's more evidence that people do get some protection from antibodies, which is part of the issue. There's some evidence that's not clear cut, but it's very suggestive that some of the treatments with plasma that's rich in antibodies from people who've recovered from infection may have some benefit. It's not a open and closed case. It's not absolutely sure, but there's a lot of suggestion about that, which is a very important piece of evidence to make us optimistic that there may eventually be a vaccine that could produce antibodies that would have some protection. There are some really rapid programs that are underway to develop a vaccine. And if everything goes well, they may start to have some doses available by the end of the year. But for the general public, I'm not sure we're going to have 300 million doses by then. It's a good question to ask because we just are not sure. But I think there's a certain degree of optimism.
Great. Ollie, a question for you. What's the likelihood that COVID-19 just becomes part of our normal, be it cyclical or seasonal viral illnesses that we just now contend with indefinitely going forward?
It would be a choice we make since other countries have chose otherwise. So New Zealand went 102 days without cases until they had a small cluster. China now, I think, has gone 10 days again without cases. There are 104 billion people. We were able to eliminate SARS the first time, SARS-CoV-1. So this is a choice. I mean, without a doubt, this is clearly the greatest public health failure in this nation's history. We are the unique outlier anywhere in the world with our herd immunity, 1,000 death a day strategy. But it will be more difficult. There's over 200 countries that are infected. Hopefully vaccine provides an option for us in 6 to 9 months, has the option to at least get it contained again, even if we never get to a state of elimination like China or New Zealand, or obviously eradication.
Thank you. Well, we are butting up against the hour, and I want to be respectful of everybody's time. And I know that Alan has some closing comments to make. So before I turn it over to him, I'd like to ask the panelists this, and I'd ask each one to respond in 10 seconds. What is the most important takeaway message you'd like to leave the audience with tonight? So Marvin, I'll start with you.
Most important message is to learn. We can't just go by preconceived ideas. We have to learn and act on that. So test, trace, isolate is going to be the cornerstone of the most effective thing we can do right now when we don't have a vaccine.
Great. Paul?
Yes, be vigilant and wear a mask.
Great. Mark?
I would second that. We know how to prevent the transmission of this illness. We have it within our power to do so. Physical distancing, mask wearing, hand hygiene, all important and what we should all be doing every day.
Great. Dan?
It's just that it's not hopeless. We know that it's been a difficult several months, but other countries have gotten control of this. If Americans change the way we behave, we will get control of it.
Allison?
Trust the science. That's the most important thing to do. As everybody said, randomized controlled trials when we are testing drugs and vaccines, trusting the data, as Dr. Khan and Dr. Poor and Paul Fay are all providing to us. We need to act on legitimate information, scientific method.
Great. Adi?
3 W's: wear a mask, wash your hands, watch your distance.
Great. And Ollie?
We can't afford to wait for a vaccine with 1,000 deaths a day. So let's get public health and governors doing what they should be doing, which is test, trace, and isolate people.
Thanks. Well, I'd like to say in closing that it's been our pleasure to share this hour with you, and hopefully we've provided you some good information, answers to questions that you were holding close to your chest. For me, it's an incredible privilege to be able to work alongside all these people on a daily basis. And for that, I'm truly grateful. And I think our community should really be grateful for the subject matter expertise that we have in our backyard, many of whom shared the virtual podium with me tonight. And we again, thank you all very much for giving us this opportunity to spend the past hour with you. So with that, I'll turn it over to Alan and Steve and say thanks again.
Harris, I just can't thank you enough for helping us put this together. And Omaha and Nebraska in general, lucky to have the experts that we have in our community that came out tonight to present to us. Every day we have issues that we have to address in our community, and to have the leaders on this panel tonight addressing those are very meaningful and very important. I can't thank you enough for the work you do daily, but I want to really thank you for being a resource to us tonight. And hopefully we will have some resolutions in the future. But truly, it's about what you've all said. Wear a mask, it's the science, and social distance. Thank you very much. There is a survey for the audience to answer at the end. Fill that out, and hopefully we can continue providing these great presentations. So again, thank you all very much, and hope to see you all healthy soon.
Mask on, everybody.